Hello, everyone. My name is Dr. Devraj Munikrishnappa. I'm a consultant nephrologist and the president of Houston Kidney Specialist Center. We at HKSC are very excited to present the first of this video series. The goal of this video is very simple. It is primarily intended to increase the understanding of kidney conditions in our patients. It is also our goal to do this in very simple terms so that everyone can understand. Therefore, it is set in the question and answer format. It is our honor and a great pleasure to have with us today the highly regarded and deeply respected leader in our nephrology community, Dr. Osama Gaber from Houston Methodist Hospital, to respond to our questions. He is the chair, Department of Surgery at the same hospital. He is also the John F. Jr. and Caroline Bookout Presidential Distinguished Chair, Professor of Surgery, Weill Cornell Medical College, Founding Director, J.C. Walter Jr. Transplant Center. Dr. Gaber, once again, it is an honor to have you with us. Thank you for taking the time from your busy schedule to be with us today. Dr. Gaber.
Thank you so much, Devraj. It's really a great pleasure to be here and to be with all of you. I think that our nephrology community in Houston is really very vibrant. And the fact that you and your group are taking on this educational series for the patients is, I think, very commendable. And I really appreciate that. And that's why I made the time, and I will always make the time, because anything that reaches to our patients is really important to us. So thank you for the vision of putting this together. I want to just say a couple of words that my introduction was really generous, and I truly appreciate that. I think I've been helped by the fact that I worked at Methodist Hospital. It's a great institution that has a history that goes back, of course, to Dr. DeBakey. And because of his legacy, the Methodist Hospital has been one of the best hospitals, actually ranked the best hospital in Texas for almost 11 years running. It's one of the top 20 hospitals in the country. And it's number 1 or number 2 on the national list of safety hospitals. So it's an amazing place to be. And this is really has been the springboard for our effort in transplantation and our relationship with all of you, because without you, working in the community, seeing people, and really directing them to get the best treatments possible, we couldn't have been there. So thank you so much for your introduction.
Thank you, Dr. Gaber. And I can vouch for that. All our patients, all our mutual patients are extremely happy and satisfied, without doubt. And thank you for the excellent service. Appreciate that. I would also like to introduce you all to our team of interviewers from Houston Kidney Specialist Center. So we have Dr. Gayat Sultan, Vice President and Consultant Nephrologist at Houston Kidney Specialist Center.
Hey, good morning, Dr. Gaber.
Good morning, Gayat. How are you?
Thanks. I'm good. Thanks for joining us.
Of course.
And then we have Dr. Sigal Exiti. He's a consultant nephrologist and partner at Houston Kidney Specialist Center.
Good morning, Dr. Gaber.
Hey, good morning.
Great to have you with us. Thank you.
Thank you. It's my pleasure.
Thank you. Then we have Dr. Jonathan Pankow, consultant nephrologist at Houston Kidney Specialist Center.
Good morning, Dr. Gaber. Thanks for being here.
Good to see you.
And we have Natalie Bernard, the nurse practitioner at Houston Kidney Specialist Center.
Good morning, Dr. Gaber. So glad to have you with us today.
Thank you, Natalie. Appreciate your work.
Thank you.
Then we have Patricia Vargas, who is the manager at Houston Kidney Specialist Center and the nurse practitioner in the making at Houston Kidney Specialist Center.
Good morning, Dr. Gaber, and thank you for having us.
Hello, Patricia.
And lastly, we have Glaucy, our assistant manager at Houston Kidney Specialist Center.
Good morning, Dr. Gaber. Thank you for this great opportunity.
Thank you, Glaucy.
Great. So we'll get started without any more delay. And again, Dr. Gaber, thank you so much. And here's our first question. All our questions are mostly going to be what the patients would like to know. And so here's the first and most important question in this day and age with COVID around. What impact does COVID have on any patient looking to get a kidney transplant, either from deceased donor or live donor?
Well, I think, honestly, just like anybody else in the country, COVID has changed the world for kidney patients. The burden of basically the social distancing, masking, and taking care of oneself is much harder on the kidney patients because of the need for communal services during dialysis time and so forth. And kidney transplantation introduces another additional problem for them because of the immune suppression. So luckily, we've been able to get through that first year of the pandemic with, I would say, small amounts of problems, but still very significant for the dialysis and the kidney patients. I think the impact should be that I hope that every dialysis patient has gotten vaccinated. And I think you want to do that and stay vaccinated so that you can get a kidney transplant with a significant reduction of the risk, because for people who are not vaccinated, the risk is a little bit higher after a kidney transplant of contracting COVID infections. And thus, the main thing now is vaccination. The second thing is some of the kidney patients and some of the transplant patients don't develop immunity to the vaccines as much as the general population. So not to let the sense of security that you've been vaccinated lull you into giving up all the care that has been done during the past year, and stay vigilant, because it's important to keep ourselves free from infection.
That's great. So essentially, continue the precautions that we're taking and get vaccinated.
Absolutely. And we
continue to seek the kidney transplant. Great.
Well, I think there is no question. So when the pandemic happened last March, we closed off transplantation for just a very short period of time, particularly the living donor transplants. But then, based on the numbers coming from China and Europe, it turns out that the survival advantage that's afforded by transplantation is higher than the risk afforded by the COVID infection. So we resumed transplantation throughout this past year. And in fact, this past year we did, even though we were off for about 6 weeks, we did more transplants than the year before, 2019. We did have some infections in our patients, and we did lose a few patients. But still, even those that were infected and the few lives that we lost, when you look at it in the balance of the survivorship of kidney patients, definitely getting a kidney transplant is advantageous to them, rather than being afraid of COVID and waiting on dialysis.
Wonderful. Dr. Sultan?
Yes, Dr. Gaber, thanks again. So being on the anti-rejection medications, how would that impact the immune system, and how much risk we are taking, especially with the COVID around, being on lifelong anti-rejection medications?
So the immune suppression medication, I mean, it requires a little bit of understanding of the COVID pathophysiology, how COVID causes problems. There are two phases in COVID, right? The one is the viral phase, which is like any other infection that you get, like a cold or a pneumonia or an influenza or whatever, where the virus spreads throughout the body. And if you have a good enough immune system, then usually the immune system protects you from the spread of the virus, right? The second phase of the COVID infection, which is the phase that brings people actually to the hospitals, is the immune response to the virus. So that people who have a strong immune response to the virus will develop this inflammatory response syndrome where they need to be intubated, they have fevers, and so forth. So to be honest with you, immune suppression makes the first phase harder for the transplant patients because they don't have the ability to curtail viral infections fast enough. But hopefully it makes the second phase better for those patients because they don't mount a strong enough immune response to develop the inflammatory response associated with COVID. So it's a mixed blessing, but there is no question that being on immune suppression doesn't increase your risk of getting COVID. It just increases your risk of not being able to fight it successfully. So our advice to the kidney transplant patients is if you are taking immune suppression, you really need to hide a bit more carefully than all of the other people. I mean, for example, on discharge from the hospital, we ask people to wear 2 masks, a KN95 and then a regular cloth mask on top. If other people wash their hands 10 times a day, the transplant patient should wash it 20. We ask people to sanitize all the surfaces that they get in touch with, particularly kitchens and doorknobs and things like that, multiple times a day. And, considering that we did 255 kidney transplants last year, we only had like maybe 11 or 10, I can't remember the exact number, but very few infections in those very large number of patients because of keeping precautions.
Nice. Great. Thank you.
That is a very important data piece, and that's very encouraging for our transplant patients, for sure. Yeah. Dr. Exidi?
Hi, good morning, Dr. Gaber. Thank you for joining us. My question is just, what is the general recommendation for getting this COVID vaccine for patients who got transplant?
I really think that we recommend that all transplant-related patients get COVID vaccination. That includes all patients on the list, all patients on dialysis thinking of getting a transplant, and then all transplant patients. We don't differentiate between the types of vaccines. We think they're all good and safe for the transplant patients. And to be honest with you, Methodist Hospital has put together an amazing effort into vaccination. We've vaccinated almost 2,500 transplant patients in the last 3 months with very little side effects, almost none. And I think that people should get the vaccine. It's one element of protection. But like I said, we're still now looking at the data to see how many of the patients would. We know that transplant patients in general, when they take the influenza vaccine, for example, they don't develop antibodies and they don't get protection from influenza like the general population. So what we've been doing for the last 10 years is advising transplant patients to get a double dose vaccine. Now that unfortunately is not available yet for COVID infections, but we're thinking that about 30 to 50% of the patients will develop antibodies, which is the rate we see with influenza vaccination, 50%. So we're hoping that if we reach that at least half of the patients will get protection. That's why, because we don't know who's going to develop and how long it's going to last, because we don't know if the infection in the transplant patients, the immunity in the transplant patient lasts as long as the general population. So we're advising the transplant patients, number one, to get the vaccine. That's a must. And number two, to stay on the precautions and not to be lulled into a safe sense of security that they're vaccinated and they're just going to go be merry and do whatever they need to do. We all have to take care because we don't know, when the immunity goes away, who we get exposed to and so forth.
All right. Thank you so much.
Of course.
Thank you, Dr. Gaber. Dr. Padcock?
Yes, again, thanks for being here. My question is, when should a patient diagnosed with kidney disease seek kidney transplantation?
That is a very crucial question, actually, because I think there's a lot of misunderstanding about that. The data that we have shows that if you get a kidney transplant before dialysis, or within the first 6 months of dialysis, compared to people who get a kidney transplant 2 or more years after dialysis, that the 10-year survival for the patients differs significantly. It's somewhere between 65 and 35%. It's almost a 30% difference in the 10-year survival. And the reason, of course, is that the prevalence of cardiovascular disease decreases significantly in the preemptive patients and increases gradually as you head towards dialysis. After dialysis. So we want people to get transplanted before they go to dialysis. The problem is people misinterpret that like they have, renal function that's 3 and 4 cc's and they're trying to hold off until the living donor gets their workup. I think you reach a point, right? Somewhere around 10, 8, you guys know that better than I do, where if you're symptomatic, you better go on dialysis while your transplant is being looked after. So my advice to anybody who knows that they have kidney disease is to know the most important number, which is their eGFR. I'd like people that have 25% kidney function to start their workup, to start talking to their family. It takes quite a bit of time for the family to find out the information, for the patients to get worked up. And we don't usually transplant people until they are symptomatic and have clearances in the low teens, and always directed by you guys in terms of when that is important. But that gives us a chance. Some people actually will work them up and they probably have such slow progression of the kidney disease they may never need a transplant. But it's okay, because if they do, then we are prepared. And a lot of the patients end up by needing, cardiac catheterization, maybe open heart surgery, something done before a transplant. We have enough time to do that before they get to dialysis. So my feeling is, just as you are seeing the patients, we should be sort of making that initial assessment. Of course, because all of you have a very highly functional practice, what you do is you assess the probability of transplantation. The only thing that early referral achieves, which I think is crucial, is it gets the family involved in the decision of whether living donor or cadaver transplant, which I always hope that it's a living donor transplant. I don't know if I answered the question directly enough or not, but usually somewhere around the GFR of about 25, we'd like to see the patients, work them up, make sure they have a living donors, counsel the families, but we won't transplant people until they're in the low teens. That's when we're ready to do the transplant.
Okay, thank you.
Of course.
Yeah. I also would like to emphasize your advice, Dr. Gaber, that if the estimated GFR is low, not just wait for transplant, because we do have some subset of patients who actually would like to wait for transplant rather than go on dialysis, even though they've been so advised by the nephrologist. So I think that's an important piece of advice. When you really need it, you should
I
go
think it's
to
important, Dr. DeVraj, it's important to emphasize this point. The problem is, particularly, where it's heartbreaking, right, is there are two things that can happen if you delay dialysis unreasonably beyond the point. Now, if it's a matter of a couple of weeks and you guys think that the patient can tolerate it, I think that's great. But there are two things that I find to be really hard. One is the patient whose anemia is not responsive to treatment, right? We need to expedite the transplant because I'd like them not to get transfused, because then they can get sensitized. But at some point, some people try to hold off on the transfusion until they're very sick. And I think that that's ill-advised. So that's where we need to have communication. The other part is the patients with pre-existing cardiovascular disease. They probably need to be put on dialysis earlier rather than later, because then removal of the fluid, lowering their pulmonary artery pressure, decreasing the amount of stress on the heart is much more advantageous, because they can have the transplant as an elective procedure rather than have the transplant and then be in heart failure and have problems after transplantation. So I think that's where our relationship is so important, that the patient has to be in the middle, but really listening to both, and we have to coordinate it so we can give them the best advice possible. But I don't think you want to hold off against your medical advice, because I think that it's pretty dangerous, actually, to try to hold off on dialysis.
Wonderful. Thank you, Dr. Gaber. And Natalie?
Dr. Gaber, are there any differences in kidney transplant and its outcomes depending on what modality of dialysis? For instance, peritoneal dialysis, home hemo versus intermittent dialysis?
So there's been a lot of data about that. And I think that in general, the post-transplant outcomes is not truly affected by the modality of dialysis in as much as the modality of dialysis itself, but at the indication by which the patient went in peritoneum versus, let's say, for example, hemodialysis, right? Because if you think of it, a lot of times you're putting people on peritoneal dialysis because they have cardiac disease or something of that nature that makes hemodialysis, less of a preferred treatment. And that in itself is the risk factor after transplant, not the modality of dialysis. I think that people should get the most effective dialysis that's suitable for them. I don't think that choosing one modality of dialysis or the other is going to affect the transplant outcome. So they should listen to you in determining the modality of dialysis, and we will work with whatever modality they come with and whatever comorbidity they have to try to get them a safe transplant.
Thank you.
Great. Patty?
Hi, Dr. Ray. If there's a patient who's close to needing dialysis, would getting on dialysis impact getting transplantation in any way?
Like I said, if they got on dialysis, the outcome may be better if they are, they have a high pulmonary artery pressure and they're going into heart failure, if the blood pressure is out of control, if the potassium is out of control. Getting to dialysis is a life-saving thing. So it will make the kidney transplant outcome better. It's those patients that, how would I say it? There's quite a few patients that try to protect others from giving them a kidney. They don't want to talk to their families. They want to go through it alone. They want to wait on the list because they think, and the average time waiting on the list is about 5 years. The mortality of patients after 5 years of dialysis is relatively high. So that I think dialysis without it, people wouldn't survive. So I think people should get on dialysis when they need to, and they should work on getting transplant as early as they can. Because these two things are not contradictory, right? People misinterpret this. These two things are not contradictory. You should get a transplant as early as you can. A lot of times you can't. I mean, and we're going to talk about that later on, about matching, cross matching, and things of that nature that delay transplantation. You have to get adequate dialysis, and then you need to get a transplant as early as you can.
Thank you, Dr. Gaber. Glauci?
Dr. Gaber. So just clarifying, getting on dialysis could in any way delay or preclude a kidney transplantation?
No, it does not. I don't think they are related. I just would like to have people, or a large proportion of the patients transplanted before they get on dialysis. If they do all the correct things, talk to their family, have a living donor, schedule the workup early enough, maintain their diets, and do what is good during that pre-uremic, pre-dialysis phase, because you can't come and say, I'm going to hold off on getting dialysis and your potassium is 7, right? I mean, it just doesn't work. So I think if you really have good follow-up, follow the doctor's advice and so forth, I think you'll be able to get your transplant hopefully before dialysis. But if an emergency happens, something changes, again, I think dialysis is the safety valve. It makes you survive that pre-uremic phase. And I just don't, I would get dialysis if I needed it while I'm working on a kidney transplant. No, it does not preclude them. And in a lot of cases, it makes them in better shape. In a lot of cases, we actually ask them to get dialysis before we transplant them, just because they have side effects from the fluid overload and the metabolic derangements that we couldn't transplant them without them getting dialysis first.
Thank you, Dr. Gaber. I have a very simple but commonly asked question by the patients. How long can the transplanted kidneys last?
So I think people use statistics the wrong way when they answer that question. So this weekend, I talked to a patient of mine that I transplanted when I first graduated from my fellowship. I don't want to tell you that was it's only 30 years ago. And our patient has amazing function, works full time, right? And I mean, but if you look at all kidneys, the numbers we quote to people is something called the half-life. And the half-life is a number. If we take all the kidneys we transplanted and follow them into the future, 50% of them will survive a certain number of years. And that's what people look at it and say, okay, a kidney transplant will last 7 to 8 years. That's the half-life of a cadaver kidney transplant. But it means that 50% of the kidneys will survive even longer than that. Now, how much longer? We don't know, right? Because we don't know what the full life is. We know that 50% of the patients, not of the years, okay? 50% of the patients have 7 to 8 years with a kidney transplant. So your chances are 50-50 to have 7 to 8 years, and then to have much more than that, just like the patient I was telling you about, to have a 30-year or so. When you have a living donor transplant, the half-life is between 17 and 20 years. So again, 50% chance that the kidney will last 17 years, 50% chance that it will last much longer. The amazing thing is if you're diabetic and you have a kidney and pancreas transplant, the half-life is somewhere around 21 to 24 years. So that's a very extended life because you treat both the diabetes and the transplant. So even though the half-life is the percent of patients making it to that time, people interpreted that this is the half-life of the kidney itself, but it's not. And honestly, it depends on how you take care of it. And the problem is what I see in most patients after 3 or 4 years, they forget that they've had a kidney transplant, right? And they try to just ignore the fact that they need to take care of their kidneys. That makes the half-life short. But if you really are very good at taking care of your kidney, you're exercising, you're not gaining weight, you're taking your medication, you're watching, the chances are that this kidney can last a really long time. But again, the half-life is 7 to 9 years for a cadaver kidney and 17 to 20 years for a living donor.
Wonderful, excellent. Yeah, very important piece. Thank you, Dr. Gaber. Dr. Wilson?
Yes, Dr. Gaber, is there any difference between living and deceased donor in terms of complications, rejection? You already mentioned living donor, basically they have longer survival. About complications in terms of rejection?
I mean, so we think that if a kidney is done with low preservation time, the chance of rejection is less. So even if you take a cadaver kidney and you're able to do it faster, the chance of rejection is less. Of course, the living donor kidney only stays out of the body for like half an hour, 45 minutes. Mm-hmm. So that really decreases the chance of having a rejection. But to be honest with you, living donor kidneys have an inherent set of risks themselves, right? Because the blood vessels are smaller, the risk to the donors and all of that sort of thing. I think that the living donor kidneys have better outcomes in general because of the very high selectivity of the donors that we do. Mm-hmm. It's different when somebody has died in an accident and they're already died and you have to take that kidney. You don't know much about the lifelong history of that person. But in a living donor, we have the chance to see the donor, to talk to them, to work them up, to know a whole lot more about their kidney function, to detect the disease. I mean, I think like the other Dr. Gaber, my wife, had just reported a paper about the presence of IgA nephropathy in cadaver donors, right? I mean, it's almost 20-some%, right? That's unknown or unrecognized. Of course, not all of it is disease, but a lot of it is staining, right? But the 20-some% of the patients that we get cadaver kidneys from have some form of IgA nephropathy in the kidney. I mean, it doesn't affect the outcome that much, but it can. And so we don't know about those cadaver donors. We know about the living donors. We study them. We make sure that the kidneys are working well. There's no protein. We know the clearance. We try to match them to the size. We try to match them to the age. So we do a whole lot more fine-tuning of a living donor kidney than we do with a cadaver kidney. And that makes a difference in the outcome.
Excellent piece of information. Thank you, Dr. Gaber. Dr. Exidi?
My question is about those transplant patients on a transplant list or the patients waiting for a transplant. Some patients say like they would rather wait for like the perfect kidney to show up. And how do you, or what's your general recommendation as to how you can help them make that decision?
It's a hard question. Okay. My preference is you don't wait for a kidney. You get your family to give you a kidney, or your friends, or you get a living donor kidney. That's my preference because, like I said, that's the best kidney you're ever going to get. It's going to decrease the waiting time. It's going to decrease the risk of dialysis. Okay. Now, if you tried very hard and there is no living donor kidney and you have to wait on the list, it becomes a really difficult question for the patients. Because we know, statistically speaking, that getting any kidney is better than waiting on dialysis. So if you can get a kidney, even though it's not a perfect kidney, you will survive longer than if you wait on dialysis. The problem is after you wait 5 or 6 years on the waiting list, chances are you're closer now, because now waiting time is the most important determinant, right? So the chances are you want to get the best kidney that you can. Now, that's where knowing where you're being transplanted is important, because what we do is we do a lot on behalf of the recipients. We actually try to keep our acceptance of the kidneys. If you have somebody who's been on the waiting list for 13 or 14 years, has very high level of antibodies, gets a kidney transplant, and it's a cross-match negative kidney, my advice to them is take that kidney. And if we think we're going to make it work, take that kidney, okay? Because if you pass that kidney, there's no more 13 years you can wait. I mean, it's a done deal. But if you've been on for like 4.5 years, you get a kidney that's not really very perfect or very, a kidney that I would want to put into you, I will tell you that. And then you can make your own decision. Some people are just so tired of dialysis, they want to just go ahead and do that. And some other people say, okay, I think that I can wait. And I think that is debatable. It's not paternalistic. I can't make the decision for them, but I want them to be part of the decision because it's important. And to be honest with you, that's one of the hardest questions. I put myself in the patient's position. It's one of the hardest questions to answer. But there is no perfect kidney. I just want to tell people there is nothing called a perfect kidney. Every kidney, because for a cadaver donor to give you a kidney, there has been an injury to that person. That person was either shot, had a car accident, died of a stroke, must have had some pre-existing disease. There is no perfect kidney. It's just a matter of the spectrum of which kidneys do you get. And I think the best thing to do is to consult with your transplant center, know their outcomes and the results. If they have really great outcomes and really great results, then they're not just putting kidneys into people that don't need them or putting bad kidneys into good people. I mean, and I hope that people on our list feel very comfortable with us that we can make that decision together.
Thank you so much.
Thank you, Dr. Gaber. Dr. Penko?
Yes, I'll ask you my question. I think you actually answered it already, but if I am content on dialysis, why should I even get a kidney transplantation?
Well, I mean, nobody can force you to do anything you don't want. I think what you need to answer the question to yourself is, what does content mean? I think that if the quality of life is okay for you, if the survival advantage is not that important for you, then great. Now, there are people who I actually ask them, how are you doing in dialysis? And they say, I'm just doing fine. And for them, I say, I probably wouldn't advise a kidney transplant for you. So it's not a crazy concept. But if you got somebody who's in their, mid 70s or so, that have a long history of longevity in the family, that are doing well on dialysis, have had no hospitalizations the last 2 or 3 years, have good heart function, right? And I know that by giving them a transplant, is going to change their lifestyle so drastically. They have nobody to take care of them, or a spouse that herself or himself is sick and can't manage them. Disrupting their system, right? We have data on survival that shows transplantation makes you live longer, but that data stops at about 75, 76 years. Once you get beyond that age, right, it's almost an elective transplant. So what you're saying will apply for these people. But I find that very hard to believe in somebody who's 20 or 30 years of age, because they do get 10, 11 years of added survival if they get a kidney transplant. So for these people, they just need to know the fact. Does that answer the question?
Yes, absolutely. Thank you.
Of course.
Yeah, and I think our patients will certainly benefit from your response, Dr. Gaber. We do find some subset of patients, younger patients, actually likely eligible, for kidney transplantation, having that notion, well, everything is going smooth, so why change things? So educating them that they're likely to live longer and have a better quality of life would certainly help.
And a kidney transplant is like a marriage, right? You don't enter it until you're convinced that this is what you want, because it will take work to make it work, right? And if you're not going to work at it, there's no reason to approach it, because it's going to fail, right? I mean, you have to take your medicines, you have to go to the doctors, you have to watch your diet, you have to do exercise. I mean, people think that if I get a kidney transplant, I'm done. I'm done with kidney disease. And that's not true, right?
Not true.
You got a kidney transplant, you're at a different phase in your kidney disease, and you need to keep protecting that kidney so you don't go back into the earlier phase. But it's not true that you're completely cured. You do need medical management and care and so forth, but you have the freedom and the improved survival. These are the two things that kidney transplantation does. It gives you significant improvement in the quality of life and gives you additional years of life to live. So that, and I think both of these are really good to have.
Great. Thank you, Dr. Gaber. Natalie?
Dr. Gaber, so what can I do to expedite the process of getting a kidney transplant?
I don't know that you need to expedite the process, but here's what I'm going to tell you. The kidney transplant has some form of a pre-planned workup. And you can't believe the number of reschedulings that people do before they get their workup done. If you want to expedite it, show up, you get it done. You go talk to one of these wonderful doctors that are there and say, they want me to do X or Y and Z. Can you help me get it done? But I think the most important thing to expedite getting a kidney transplantation is not a patient issue. It's a family issue. And I think the first thing you need to do if you want to get a kidney transplant, don't show up to my office by yourself. I want to see your whole family. I want to talk to everybody, because that's the biggest expediter of your transplant, is somebody wanting to donate a kidney to you. You have to understand that when people give you a kidney, it doesn't affect their survival. It doesn't affect their ability to have children. It doesn't affect their jobs. It doesn't affect the long-term outcome. They don't take any medications. We don't cut them open. We make little tiny holes around the belly button and take the kidney out from them. Donors leave the hospital the next day. It doesn't cost them money. Being worried about getting a living donor is like being worried about the monster in the closet. If you don't open the door and look there, you'll always think there is a monster in the closet. And I think that there is no monster in the closet. We do hundreds of these, thousands of them. And there is no monster in the closet. That's the earliest thing, the best thing to do to expedite your workup or to expedite your getting a transplant, is to make it a family issue. Talk to everybody. You'll be surprised. I mean, people come to me and say, well, my kids didn't offer. Well, how can they offer when they don't know the facts? How can they offer when they don't know what it's going to entail? And I think what we need to do is we need to have a family discussion around this. And that's why I got somewhat frustrated when people show up to clinic and they're by themselves. Because how are you going to get a kidney transplant by yourself? You've already predetermined the destiny. It's going to be slow, it's going to take years, and so forth. So that's Natalie, when you see those patients, right? You're going to send them for a transplant consultation. Ask them to bring their family with them. We're happy to have them. We're happy to talk to all of them.
Excellent. Patty?
And Dr. Gaber, what does a kidney transplant entail as far as a surgical procedure, and what are the risks?
Well, kidney transplantation, you get the kidney out from the donor, and the kidney has usually one or multiple blood vessels and one vein or a couple of veins and a ureter. And what you have to do is you have to find the artery and the vein that go into the leg, and you try to put the kidney transplant in the groin based on these vessels. So you do what we call vascular anastomosis. You stitch the blood vessels together, and then you stitch the ureter to the bladder so that the urine will find its way to the outside. To be honest with you, kidney transplantation risk, surgical risk, has decreased so significantly over the past 30 or 40 years. I mean, it still does have a risk of bleeding, infection, but in general, the risk of the procedure is small. The biggest risk from the patient's perspective is actually that the kidney doesn't work right away. And that's a problem when you get kidneys from cadaver donors, because then if the kidney doesn't work right away, then it brings back the need for dialysis in the immediate postoperative period, which is harder than the elective dialysis. It puts them at risk for heart failure. There are biopsies, there are modifications in the immune suppression. So that's why we try to cut down or cut short the time that the kidney stays outside of the body, to use more living donors, which tend to work right away, and so forth. But in general, the surgical risks per se are small. More of the risk of the transplant procedure is really the management risk. Does it work? How much immune suppression? Do you get an infection? Do you get a rejection? It's your immune system, and so forth. But the surgery part, and maybe it's because I've been doing it for a long period of time, but if you look nationally at the surgical results, they're excellent. It's become a standardized operation.
Thank you.
Thank you, Dr. Gaber. Glossy?
Okay, so Dr. Gaber, if I'm still urinating with my native kidneys, what happens to my native kidneys after the transplant?
Excellent question. And there are two scenarios usually. One is that the native kidneys, will continue to work at a very low clearance, 3, 4, 5 cc's. In some cases, the new transplant kidney takes on the whole function. I like to think that they continue to work even at low levels, because all of you know that, for example, there have been data about patients who take peritoneal dialysis, and if they have even 3 or 4 cc's of clearance from their native kidneys, they have advantage in survival. I like to think that those native kidneys will continue to work with at very reduced clearance. It adds every cc of clearance, whether it's from the native or from the transplant kidney, every 1 ml of clearance that you gain really has an impact on your long-term survival. So I hope that they continue to work, but the majority of cases, the function gets taken over by the transplanted kidney.
Basically, so someone had been told that they don't have adequate blood supply, and therefore they cannot get a kidney from a donor, even though.
I see. So there are 2 reasons for that. One is that the blood vessels, people on dialysis have calcium abnormalities and they have atherosclerosis. And so sometimes the blood vessels are calcified enough that the transplant people say that they can't put a kidney, although we usually find a solution. So if that's the case, then what we would need to do is we'd need to do a vessel replacement, and we have many ways to do that, so we can put the kidney transplant on a blood vessel. The problem is if the local vasculature is obstructed to that extent, then usually there is pretty significant cardiovascular disease that will preclude transplantation. But the other reason for not having enough blood flow is that people will have heart failure problems or problems with cardiac output that would not support the kidney. And some of these patients, in fact, do better on dialysis because you can take a whole lot more fluid on dialysis than you can with the kidney transplantation. So it depends on the usual situation. But I want to tell people, if you're ever told that, check back with us, because we hopefully could try to do something and we can reconsider. Sometimes that's just the first opinion that comes by, but we can reconsider that.
Great. Thank you, Dr. Gaber. Dr. Sultan?
Yes, Dr. Gaber, are there any health conditions that will exclude any patients from being on the transplant list?
So, I mean, to exclude, I mean, we have absolute contraindications to being on the transplant list, right? So if you have uncorrectable heart problems, that's a main reason why you can't be on the transplant list. If you have very fresh malignancy, that's the reason why you can't be on the transplant list. If you have really challenging psychosocial problems, like there's no way for you to care for yourself or for your family to care for you after a transplant, that's the reason why you can't be on the transplant list. If you don't take care of yourself, if you have been non-compliant, not taking care of yourself on dialysis or in your medical therapy, you can't expect to be on the transplant list, because that the transplantation increases the need for compliance very significantly. But everything else after that is a relative contraindication. It is something you can work through. So, for example, if you take somebody who's had a long history of non-compliance, right? They haven't been following doctors. What you need to do is we'll put you in a compliance contract. We say, okay, for the next 6 months, this is what you're going to do. And if you follow that, we will then put you back on the transplant list.
Great, very helpful. Thank you.
The general recommendation for fertility is to avoid having children in the first year after a transplant. But then after that, with proper planning, because some of the medications we give have to be stopped, some of them have to be changed. With proper planning, most women are able to have children. We've had a registry of thousands of children that have been had from transplantation. It's just higher risk pregnancies, so they need to get some specialized care, both from the transplant center and from the OB doctors. But in general, the majority of women are capable of conceiving and having babies, and men also are capable of fathering babies after transplantation. But both men and women, I mean, we don't think of the men as needing to change their medicines, but they do, because some of the medications that we have, there is recommendation to change them if you're going to have a child, because of the risk of abnormalities in the child. But in general, pregnancy after transplantation is safe as long as you go through that first year where the immune system is still very active.
Okay, thank you so much.
Yes, this is maybe a broad question, but I was hoping that you could maybe outline or describe the steps involved of actually achieving a kidney transplant in the United States.
It's very simple. You call your transplant center, you come in and you're seen by the transplant program. You schedule your workup. We like to do it in the transplant hospital for the most part, so that we can have the records and have our consultants see you. Once you are completed your workup, if everything is okay, you're going to get to be put on the list, which is a national list. The national list is guided by the policies and the procedure of the National Transplant Organization. And so the order in which you get a kidney is determined by the rules that have been set by the national organization. And when you get a call in for kidney transplantation, you hear about the donor, you decide this is a kidney that I want, and you come in and have a transplant. I mean, it's pretty standardized process, actually. The big difference that we've been trying to do in the last 5 years, is shift from putting people on lists. I think that's the wrong approach to getting the families involved and getting people to give living donors. And as a result, we're the third largest living donor program in the country. We did over 120 living donor transplants this past year. We're now 50-50. We're doing 50% of all of our transplants from living donors and 50% from cadaver donors. My goal is to reach 80-20. So 80% of all transplants will be done from living donors, 20% will be done from cadaver donors, because as we talk, the outcomes are better, the waiting time doesn't exist, and you can save more lives doing this than by waiting on a list. I think this whole concept of being on a list is just something from the 60s, right? When we had more donors than we had kidneys, than we had recipients. But now we have 130,000 people waiting on the wait list. We only do like maybe 20,000 transplants a year. There's almost 85,000 people every year that sit on the list. So just think of yourself standing in a line that's 85,000 long to get a kidney transplant. I think that's not a very encouraging thing.
Dr. Gaber, it has been very interesting, very nice, and very informative to have interacted with you. And thank you for your excellent sharing of the knowledge. And it certainly is going to help our patients a lot. Again, I know you're very busy, and I appreciate your time. I would also like to point out, that we will be putting up this slide where to get a hold of you and your program for our patients, in case they're interested in asking more questions and pursuing their transplant wishes. Again, thank you very much. I really appreciate it. Thank you, everyone. Dr. Gaber, it's a pleasure, and I'd like to see if we can do another session of question and answers in the future. I appreciate it.
Well, I want to also thank you for the vision of putting this together. I want to tell everybody who's interested, we have a series of transplant webinars for all the patients on our list and all the patients that have been transplanted. And maybe Glossy can work with our outreach people to link your patients to that, because there's much more information given by my partners and everybody about all the topics that you asked me about today. I'm happy to come back and talk to all of the patients. I think patient education is part and parcel of what we do as physicians, and I would be really happy to do that again with your group. Thank you so much.
Thank you. Appreciate it. Thank you, everyone.